Welcome to the Bladder, Renal Cell, and Testicular Cancers module. I am Dr. John Bazar. I'm an Associate Professor of Pharmacy Practice at the Bill Gatton College of Pharmacy in Johnson City, Tennessee. This presentation is part of the ASHP ACCP BCOP Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. This activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. Learning objectives for the bladder and renal cell module. You should be able to design an appropriate patient-specific treatment, supportive care, and monitoring plan, taking into consideration efficacy and safety outcomes from clinical trials and current treatment guidelines for patients with bladder, renal cell, or testicular carcinoma. Discuss short and long-term goals, including post-therapy and survivorship with a patient with bladder, renal cell, or testicular carcinoma and his or her caregiver. Now, a lot of that second objective is covered in the handout that accompanies this presentation, and then develop an appropriate plan for preventing, monitoring, and treating adverse reactions associated with the treatment with tyrosine kinase inhibitors and mTOR inhibitors. Much more detail in the handout on that objective as well. And then finally, I'll mention that this presentation covers bladder and renal cell, especially clear cell histology renal cell carcinoma. That's in the presentation. Non-clear cell renal cell and especially testicular cancer is covered in the handout, which makes sense when you think of the recent changes we've seen in the treatment of bladder cancer and renal cell carcinoma compared to the treatment of testicular cancer, which maybe hasn't changed as much. We'll begin our presentation talking about bladder cancer before moving on to renal cell carcinoma. This brings us to our first patient case. CT is a 71-year-old male who presented to the primary care doctor with complaints of hematuria and urgency. He was referred to a urologist for cystoscopy. Subsequently, he underwent a TURBT, which is a transurethral resection of the bladder tumor, followed by single-dose intravesicular chemotherapy, which revealed TIS, carcinoma in situ, which is a non-muscle invasive bladder cancer or urothelial carcinoma. What is the best treatment for MS? Intravesicular BCG, intravesicular mitomycin, systemic gemcitabine and cisplatin, or no therapy is needed at this time. The best answer for this case, this question, is intravesicular BCG. This is somewhat of a typical presentation with hematuria followed by TURBT and then peri-procedure intravesicular chemotherapy, which is why we wouldn't continue typically with adjuvant mitomycin going forward or induction. There's no reason for systemic therapy, but we do know that intravesicular BCG does help prevent recurrence, making A the best option. Big picture summary of the treatment of non-muscle invasive bladder cancer, which is the vast majority of all cases of bladder cancer. Like 70 to 80% of all bladder cancers in this country are non-muscle invasive bladder cancer, which is usually treated with TURBT, and then intravesicular BCG and intravesicular chemo. The intravesicular treatments are localized treatments inside the bladder as a mainstay for non-muscle invasive bladder cancer. For muscle invasive bladder cancer, the mainstay of therapy historically has been a neoadjuvant cisplatin-based chemo followed by cystectomy, which with a goal of cure. And then in the metastatic setting, our treatment overview includes platinum-based chemotherapy, immunotherapy, most notably in the form of immune checkpoint inhibitors these days, and targeted therapy, which is an emerging field in bladder cancer treatment. So let's talk a bit about treatment of non-muscle invasive bladder cancer. The most common type of bladder cancer, roughly 70 to 80% of cases, again, of bladder cancer are non-muscle invasive. And this is either TA, papillary, TIS, or in situ, or T1 tumors. So these tumors arise from the urothelial cells in the bladder, but are not yet invading the muscular layer surrounding the bladder. For example, a T1 tumor will invade connective tissue, but not muscular tissue. In all three cases of non-muscle invasive bladder cancer, all three stages, the initial treatment is a TURBT, that transurethral resection of bladder tumor, followed by perioperative intravesicular chemo, ideally within 6 hours typically with mitomycin gemcitabine. And that's been shown to prevent recurrence. Following that, for all 3 stages, BCG is the preferred induction or adjuvant treatment. Chemotherapy would be an option for papillary or T1 disease, but typically would be reserved for folks who are BCG intolerant or refractory. Following the induction BCG, and the duration of that and the number of cycles is unknown what the optimal schedule is. It's followed by some maintenance, and that varies with the patient's risk, and again, we don't know the optimal schedule. Intravesicular treatment of bladder cancer is a form of localized therapy where the drug is instilled directly into the bladder and then retained for 2 hours. In the perioperative setting, this is usually gemcitabine or mitomycin. And this can be done within 24 hours of TURP, but ideally within 6 hours, which should be enough time for the tissue sample from the TURP to go to pathology and get a quick review to figure out the next steps. Typically following intravesicular perioperative chemotherapy, that's followed by induction or adjuvant BCG, typically preferred over intravesicular chemo, as we went over on the last slide, followed by maintenance therapy that is intravesicular. There are some cautions, though, to intravesicular treatment, and that could be patients following an extensive TURP. So if there are many lesions that need to be removed, or if there's suspected bladder perforation, generally the more damage done to the bladder during the TURP, the greater caution that needs to be exercised with intravesicular treatment. Bacillus calmette-guerin is an old tuberculosis vaccine. It is a live attenuated or weakened strain of Mycobacterium bovis that was used in worldwide in the past as an immunization for TB, and it is instilled intravesicularly, which creates a local immune response in the bladder that will include an immune response to the urothelial cancer cells. So this is a very, very early form of immunotherapy. And that immune response includes, as you see there, release of cytokines like IL-2, IL-8, and tumor necrosis factor alpha, recruiting more immune cells to the bladder, where you'll see some inflammation and then also tumor cell death. It is instilled intravesicularly, typically, weekly for 6 weeks is common, and then say every 3 weeks thereafter, for a couple weeks, and every 6 weeks thereafter. And that schedule of maintenance can be determined by follow-up cystoscopies and whether or not there's recurrence or how fast the lesions reappear if they do reappear. Now, some of the toxicities here are some flu-like symptoms for a day or two following the installation, as well as dysuria, which is a local toxicity of the BCG vaccine. Chemotherapy can be instilled into the bladder as a form of intravesicular treatment. Both mitomycin and gemcitabine are Category 1 recommendations, but gemcitabine is preferred over mitomycin because of mostly its tolerability. Now, both these agents are commonly used perioperatively, so following the TURP, but may also be an option for patients who are intolerant to BCG due to severe dysuria or flu-like symptoms, or for those folks who say have an early disease recurrence of their papillary or in situ tumor following induction BCG. There is very little systemic absorption, so we don't have a lot in the way of systemic toxicities to worry about. And finally, I'll mention that we're talking about good old generic mitomycin, not the new FDA-approved formulation of mitomycin. That's the gel, the thermo-activated gel. This is traditional mitomycin we're talking about. Patient who presents with non-muscle invasive bladder cancer, TA, TIS, or T1, they get their TURP-T, they get some perioperative, say 6 hours later, some perioperative gemcitabine followed by some induction BCG, and oftentimes when they're getting their induction BCG, that's followed by a cystectomy to look to see has the disease recurred, is it recurrent or persistent? And that can then dictate, obviously, the next course of treatment. We would love for the disease not to come back, but when it does, depending on how frequently and how fast it comes back, how many of the tumors recur, sometimes patients will have multiple non-muscle invasive bladder cancer lesions. So if somebody presents with multiple lesions and just one recurs, say several months later, that would be a lower risk than if they all recurred in a shorter period of time. And that all of those risk factors do dictate what the next treatment is. And that could be a change of intravesicular treatment. So changing from, say, a BCG-based induction strategy to gemcitabine. Potentially cystectomy, so surgical removal of the bladder, could be an option, as well as pembrolizumab based on some emerging data for those who are BCG unresponsive, that have high-risk TIS disease that could or could not include papillary tumors, and who are not candidates for cystectomy. So far, that pembrolizumab study was specifically in patients who could not receive a cystectomy, which you feel more confident about being curative. And obviously, if you remove the bladder, there's not going to be a chance for bladder cancer recurrence, although that certainly does have quality of life implications. When you remove the bladder, the urologist have to create a neobladder, which obviously is not going to be able to hold as much urine as a native bladder. Non-muscle invasive bladder cancer, we're using local treatments only. There's no systemic therapy for the most part. There was that caveat about using pembrolizumab for BCG refractory recurrent disease in patients who are not candidates for cystectomy. But in general, we're using local treatment, so TURBT, followed by perioperative intravesicular chemo, and then induction intravesicular therapy in the form of more commonly BCG or intravesicular gemcitabine or mitomycin, and then some maintenance therapy as well. Recurrence is not uncommon, and these patients often will go fairly frequent cystoscopy, where a scope goes into the bladder to look for recurrence, potentially with repeated TURBT for recurrent disease, followed by intravesicular treatments based on the risk factors, based how many tumors, how fast they come back, if they do come back, what's the time frame. All that dictates that treatment going forward. And this is how non-muscle invasive bladder cancer is treated. It's a lot of local treatment, looking into the bladder and then giving treatments directly to the bladder. Transition from non-muscle invasive to muscle invasive bladder cancer. We're going to do a TURBT initially to determine stage, and that's because we need to determine the depth of invasion. So we need to see that the tumor is invading the muscle layer surrounding the bladder, and that gets us our muscle invasive bladder cancer, which will be, a T2, T3, or T4 lesions. That typically is going to be followed by neoadjuvant cisplatin-based chemo prior to cystectomy, and that's recommended for our stage 2 and 3A lesions. Now, there is no evidence that using neoadjuvant treatment is effective in non-cisplatin candidates. So there really is something incredibly important about cisplatin in bladder cancer. If somebody is not a candidate for cisplatin, we don't have any evidence say that a carboplatin-based neoadjuvant treatment is effective. The radical cystectomy also includes a lymph node dissection, and that could also include removing part of the prostate or the prostate in men, as well as hysterectomy in women. A partial cystectomy may be an option if patients are seeking something beyond a full cystectomy, or if they're not able for medical reasons to have a full cystectomy. I always find it helpful to think of the history and the timeline of how we got to where we are, because I think sometimes that is important context for where we are going in treating these cancers. This slide shows just briefly 4 kind of landmark trials in bladder cancer. You'll notice the 2 in the gray boxes are actually advanced and metastatic disease studies. And the title of the slide is Role of Neoadjuvant Chemotherapy, and that may be a little puzzling. You'll see there in the light blue boxes the neoadjuvant MVAC study in 2003 that showed an improved overall survival with neoadjuvant chemo followed by cystectomy. Compared to cystectomy alone, this really was groundbreaking and established a role for neoadjuvant cisplatin-based chemotherapy in the treatment of potentially curative muscle invasive bladder cancer, improved overall survival with a p-value 0.06, and improved pathological complete response rate as well by more than half, meaning that when they did the surgery, patients were more than twice as likely to have all their disease go away with cisplatin-based chemotherapy prior to surgery. There was also the neoadjuvant dose-dense MVAC study, which we'll talk about in a later slide. The reason I have these advanced disease trials on here is you'll notice that when we get to our guidelines that options for neoadjuvant chemo include dose-dense MVAC, or gemcitabine and cisplatin. And then gemcitabine and cisplatin role in neoadjuvant chemotherapy is extrapolated from its study in advanced disease. We do not have like a randomized phase 3 study of gemcitabine and cisplatin in the neoadjuvant setting. However, there is a phase 3 randomized controlled trial in process going on right now of dose-dense MVAC versus gemcitabine and cisplatin. And those results are expected in the middle of this year in 2021. Our preferred neoadjuvant chemotherapy regimens, gemcitabine and cisplatin for 4 cycles. And again, the inclusion here is extrapolated from gemcitabine and cisplatin's rough equivalent activity in the metastatic setting to dose-dense MVAC. Now, these patients generally in studies to define cisplatin eligibility use a criterion of a creatinine clearance above 50 or 60 mils per minute. In the kind of the landmark Grossman study in 2003 that established dose-dense MVAC as the potential or as the treatment of choice at the time for neoadjuvant treatment of muscle-invasive bladder cancer. In those patients, if they had a creatinine clearance above 50, based on like Cockcroft-Gault, they would do a 24-hour urine, and in many of those patients who would not have been otherwise been eligible by doing a 24-hour urine and calculating creatinine clearance the old-fashioned way, are actually calculating it and measuring it. Many of those patients resulted in a creatinine clearance above 60 and were eligible for cisplatin, which I think is an important point to consider as we're often the ones as oncology pharmacists determining that renal eligibility if the oncologist or urologist is looking at it that way. But that's why GemCis is included as a preferred neoadjuvant chemo regimen, again, based off extrapolation from studies in the metastatic setting or dose-dense MVAC for 3 to 4 cycles, and because it's dose-dense, it does require GCSF support. If you are relatively new to oncology pharmacy, there is a good chance you may not have seen dose-dense MVAC. It certainly, as we just mentioned on the last slide, is a preferred option for neoadjuvant chemo, for cisplatin-based chemo, for muscle-invasive bladder cancer. But we'll see that its toxicity profile is a little harsher compared to cisplatin gemcitabine. However, in the neoadjuvant setting, it really does have the best evidence and is still a preferred option. So this is really a feasibility study from 2014 looking at neoadjuvant dose-dense MVAC to see if this would work. This was a study of 44 patients that had muscle-invasive bladder cancer. You can see there that the inclusion criteria were a creatinine clearance above 50. Now, there were 14 patients who did not meet that criteria initially. And then following a 24-hour urine, they then met that inclusion criteria of having a creatinine clearance above 50, but less than 60. So again, that's a point to mention there for folks that if you do your Cockcroft-Gault estimated GFR and it's below 50, it may be worth doing a 24-hour urine because cisplatin-based chemotherapy is incredibly important for cure in the neoadjuvant setting prior to cystectomy and curative surgery. You can see there that MVAC, as you might expect, is fairly toxic when you see methotrexate, vinblastine, doxorubicin, and 70 milligrams per meter squared of cisplatin every 2 weeks with pegfilgrastim support for 3 cycles. And this was looking back at a historical control of PCR. The PCR rates here were 38%, almost identical to the earlier study of neoadjuvant MVAC. And there were an additional 6 patients who were downstage from muscle invasive to non-muscle invasive bladder cancer. And importantly, in the neoadjuvant setting with some pretty toxic chemo, there were no treatment-related deaths and no incidents of grade 3 or 4 renal toxicity. And go back now and revisit our case of CT. And he went on to receive maintenance BCG, which was preferred for him to intravesicular mitomycin because of the nature of his disease. However, despite his maintenance BCG, he developed gross hematuria later. Repeat TURBT showed muscle-invasive urothelial carcinoma, and the staging subsequently showed pelvic metastases. So he now has metastatic bladder cancer. Further pathologic analysis reveals PD-L1 tumor-infiltrating immune cells covering 2% of the tumor area. His performance status and renal function continue to be excellent. So let's say his performance status is ECOG 0, renal function, creatinine clearance above 60. Which therapy would be most appropriate at this time? The best answer for this case is dose-dense MVAC. Cisplatin and gemcitabine would also be an acceptable option in this case as well. Any cisplatin-based chemo would be the most appropriate for this patient. A carboplatin-based regimen would not be appropriate unless the patient were not a candidate for cisplatin-based chemotherapy. Now, atezolizumab, and not necessarily nivolumab because of data, but immunotherapy could be an option if this patient were not candidate for cisplatin and had a higher immune staining of PD-L1 on the tumor cells. Kind of teed this up to talk about how we are now going to treat advanced or metastatic bladder cancer. Our first decision point is not going to be which treatment, but is the patient cisplatin eligible or not? Now, in clinical trials, the criteria that are often used are a creatinine clearance above 50 or 60 mils per minute, depending on the study, an ECOG performance status of 0 or 1, and adequate hearing. I did read one study where they just said adequate hearing. There was no objective evidence of what adequate hearing was. And our options are going to be gemcitabine, cisplatin, or dose-dense MVAC. Now, in patients who do receive cisplatin-based chemo for metastatic disease, if they have a complete response, partial response, or even just stable disease, as long as they don't have progression, then maintenance of avelumab for 2 years is now a Category 2A recommendation based on a study just published last year, the Bladder Javelin 100 study, that did show an overall survival benefit for those patients receiving avelumab following platinum-based chemo who did not have progression following platinum-based chemotherapy. So our options, typically most patients will receive gemcitabine and cisplatin, and we will see why in coming slides. Now let's talk about those folks who are not eligible for cisplatin due to performance status or poor renal function. You could do a carboplatin-based regimen, so carboplatin gemcitabine, followed by maintenance of avelumab, and the same criteria for using maintenance of avelumab apply for cisplatin ineligible. As cisplatin eligible, they have to have a complete response, partial response, or stable disease after their platinum-based chemo, followed by avelumab maintenance. Again, that's based on the same study, the Bladder Javelin 100 study, which summarized briefly in the handout. The full publication came out after the handout was finalized. Now, there is a potential role for immune checkpoint inhibitor treatment with pembrolizumab or atezolizumab for patients who are not eligible for cisplatin. If they have high expression of PD-L1, they could receive pembrolizumab or atezolizumab upfront without receiving platinum-based chemotherapy, even if they are a candidate for a carboplatin-based regimen if their PD-L1 expression is high. And for pembro, that's a composite or a combined positive score above 10%. For atezolizumab, it's an immune cell stain greater than or equal to 5%. In the case we went over, that gentleman had immune cell staining of 2%, which is below that 5% criteria. In the case we went over, with the immune cells of 2%, so low PD-L1 expression, that person could have received atezolizumab only if he were not a candidate for any platinum-based chemo, which means he's not a candidate for cisplatin, not a candidate for carboplatin, which is probably going to be somebody who's got an ECOG performance status of 2, someone who's in the bed, a good chunk of the day. Now, this is a little bit confusing, and we'll talk about how this kind of changed over time. But if you can handle carboplatin, generally gem carboplatin followed by avelumab maintenance would be preferred. Patients could choose to receive immunotherapy in pembro or atezolizumab only if they meet those PD-L1 thresholds that are listed there. There are some alternative regimens like gem plus paclitaxel, or gemcitabine single agent therapy. And then for patients with really good kidney function and great performance status, you could get really aggressive with ifos, doxorubicin, and gemcitabine, and that's really only useful in certain circumstances. Let's look at some of the studies that led to the guidelines that we have now. So this is a phase 3 randomized study of dose-dense MVAC versus traditional or classical MVAC. And these were locally advanced metastatic patients being treated in the first-line setting. So dose-dense MVAC was every 2 weeks with G-CSF support, or a classic MVAC given every 4 weeks. And remember, this is methotrexate, vinblastine, doxorubicin, and cisplatin. And you can see the dose-dense MVAC has higher complete response rates and overall response rates, better overall survival, better time to progression, and less febrile neutropenia because of the G-CSF support. So that's why you don't see classic MVAC in the guidelines. It's dose-dense MVAC if you're going to use MVAC. This is perhaps one of the most consequential trials in all of bladder cancer. This is gemcitabine cisplatin versus classic MVAC. 400 patients with locally advanced or metastatic bladder cancer, urothelial carcinoma. First-line treatment, and you can see here that we see similar efficacy differences with regards to median survival, response rate, but we see much better tolerability and safety in the cisplatin gemcitabine arm. You see neutropenic sepsis 1% versus 12%, grade 3 or 4 mucositis 1% versus 22%. So this established cisplatin and gemcitabine as really the go-to regimen in the metastatic setting compared to classic MVAC. And that was then extrapolated to the neoadjuvant setting, as I mentioned earlier, which is why you see cisplatin and gemcitabine used mostly in the neoadjuvant setting. That is extrapolated from data in the metastatic setting showing similar outcomes compared to classic MVAC. So while cisplatin and gemcitabine have been the preferred first-line agent for bladder cancer for many years based on that prior study, now we have the immune checkpoint inhibitors. Now there's been some changes here. So going back to the spring and summer of 2018, the FDA sent out alert telling, a Dear Doctor letter telling everyone about decreased survival of bladder cancer patients receiving atezolizumab or pembrolizumab compared to patients receiving platinum-based chemo if they had low expression of PD-L1. That was followed a month later to a label update restricting atezolizumab and pembrolizumab only to patients who were not eligible for cisplatin-based chemotherapy. That was clarified a couple months later with another FDA update to the labels that allowed atezolizumab if the immune cell staining was more than 5%, and pembrolizumab if the combined positive score was 10% or greater, to be used in the first-line setting in patients who were cisplatin ineligible with PD-L1 expression, but were carboplatin eligible. So they did allow it to be used for folks who weren't candidates for cisplatin, but could receive carboplatin, but only if they had high expression of PD-L1. So it can be a little bit confusing, so I'll just say it again. For patients with metastatic disease, if they can get cisplatin, they should get cisplatin. If they could get carboplatin, they should definitely receive carboplatin if they have low PD-L1 expression. If they have this high expression of PD-L1 or could receive carboplatin, they could receive either agent. And we do not know yet if one of those treatments is better than the other. That will be something to watch with data coming out in the coming years. Now, because we are talking about metastatic disease, these patients do progress. So our second-line therapy, if you received a prior platinum-based treatment, whether that be cisplatin or carboplatin, then pembrolizumab is the preferred treatment. A Category 1 recommendation based on Keynote 45, which showed an improved overall survival with pembrolizumab compared to chemotherapy. Either it was investigator choice, paclitaxel, docetaxel, or evenkalcaloid. There are some alternative regimens that are listed there, and we'll talk about some of those agents in more detail on the coming slides. So we just talked about if you received platinum-based chemo in the first-line setting, then your second-line therapy of choice would be pembrolizumab. But we also mentioned that some folks who are not candidates for platinum-based chemotherapy at all might receive immunotherapy, or if they were just a candidate for carboplatin and had high PD-L1 expression, they could receive atezolizumab or pembrolizumab in the first-line setting. So now we have to have a separate branch in the algorithm for folks who received an immune checkpoint inhibitor in the first-line setting. So for these patients, our preferred regimens would be platinum-based chemo if you're cisplatin eligible, or a carboplatin-based regimen if they were cisplatin ineligible. Other recommendations could include a taxane, gemcitabine, erdafitinib, a VEGF targeting TKI if they have those susceptible VEGF or VEGFR alterations, or potentially enfortumab vedotin. Erdafitinib is an inhibitor of fibroblast growth factor receptors 1, 2, 3, and 4. It's dosed 8 milligrams daily, but the dose could be increased up to 9 milligrams based on phosphate levels. Blocking FGFR causes an on-target hyperphosphatemia. So you do expect some amount of hyperphosphatemia. If the phosphate levels do not increase to 5.5 2 to 3 weeks after starting the dose, then you increase the dose to 9 milligrams. Now, this is only approved for FGFR3 or FGFR2 alterations, and for those who progress during or on platinum or during or following platinum-based chemotherapy. There was an FDA-approved companion diagnostic test along with the approval for erdafitinib. You could detect these FGFR2 and FGFR3 alterations via that or other large next-generation sequencing panels, which are discussed in the pharmacogenomics module of the course. If you've been following oncology drug approvals, you know that if it's a TKI that was recently approved, as in the case of erdafitinib, it was based off of a study of about 100 patients based off of response rate, which is the case for erdafitinib. So this approval is based off of a surrogate marker of an objective response rate of 40% in patients who had already received chemotherapy and had these actionable FGFR3 and 2 either gene mutations or gene fusions. Some notable adverse effects included some eye toxicity, the hyperphosphatemia, an increased creatinine, stomatitis, fatigue, diarrhea, some nail disturbances, and some transaminitis. And because of that hyperphosphatemia, patients should restrict their phosphate intake, and they may have to actually modify their diet or their dose or use phosphate binders depending on how high the phosphate level will go. The last agent to talk about in the bladder cancer section is a newly improved antibody drug conjugate, enfortumab vedotin, which targets Nectin-4, which is expressed on urothelial cells, and it's linked to MMAE, which is a microtubule inhibitor, similar to what you see, obviously, with brentuximab vedotin. And of course, if you know anything about brentuximab vedotin or anything about microtubule inhibitors, you should expect that we'll see peripheral neuropathy, which of course we do. This approval is based off of patients who received prior platinum-based chemo or prior immune checkpoint inhibitor, so it's a third-line option in the metastatic setting. It showed an objective response rate of 44% and slightly more than 100 patients in the study. We did see notable toxicities of peripheral neuropathy, alopecia, some nausea, some eye disorders, skin reactions, infusion reactions, some hyperglycemia, as well as a little bit of grade 3 and 4 myelosuppression. So to summarize really the standard treatments for bladder cancer, for non-muscle invasive bladder cancer, intravesicular treatments following TURBT. For muscle invasive bladder cancer, cisplatin-based chemo followed by cystectomy. And in the metastatic setting, platinum-based chemo followed by avelumab maintenance, or PD-1, PD-L1 inhibitors for those who are cisplatin ineligible and have high PD-L1 expression, or for those patients who are not a candidate for any platinum-based therapy, even if they have low PD-L1 expression. And then we're seeing erdafitinib in a second-line setting, potentially. We still don't know the correct order, potentially in the second-line setting if they have these EGFR alterations. And then enfortumab vedotin is a new option in the third-line setting. Now that we've talked about bladder cancer, let's talk about kidney cancer. In our kidney cancer discussion with a patient case, LL is a 51-year-old male who was referred to urology after presenting to his PCP with several months of intermittent hematuria. Again, most common presenting sign of kidney cancer. His past medical history is significant only for hypertension, which is controlled with amlodipine. A workup reveals a 10-centimeter tumor of the left kidney that is clear cell in histology, the most common subtype, or the most common histology in kidney cancer, with lymph node involvement, making it stage 3. He has a radical nephrectomy and he asks if adjuvant sunitinib would benefit him. What is the most accurate response regarding the benefit of sunitinib in this patient? He is likely to see his cancer occur just as quickly with adjuvant sunitinib. LL may benefit from sunitinib, but it's going to be too toxic because of his comorbid hypertension. He's not a candidate for adjuvant sunitinib since he is not high risk for recurrence, or he is unlikely to derive any overall survival benefit from sunitinib. The correct answer here is D. He is unlikely to derive any overall survival benefit from adjuvant sunitinib, as we will discuss. While sunitinib certainly can cause hypertension, it's well controlled with amlodipine. That would not be a reason to use sunitinib because he is stage 3. He is a candidate, or he is high risk for recurrence. As we'll see, there might be a role for sunitinib. There is an FDA approval, and we'll talk about that briefly. We will relatively quickly go through the treatment of stage 1, 2, and 3 renal cell carcinoma because there's not a big role for drug therapy. Radical nephrectomy is the mainstay of therapy. You remove the kidney. For some stage 1 disease or some patients due to medical conditions, a partial nephrectomy may be tried, or ablative therapy for patients who are just not candidates for any surgery whatsoever. At this point, we have a fairly decent body of evidence assessing adjuvant TKIs for these stage 3 patients following nephrectomy to see if adjuvant TKI improves outcomes. And we see somewhat of a trend of TKIs maybe improving disease-free survival and preventing the disease from coming back, but no improvement in overall survival. And so sunitinib is FDA approved for 1 year in the adjuvant setting for stage 3 folks based on the STRAC study. But we have ASSURE and PROTECT and ATLAS. Just based on the body of evidence, this may be chance what we saw in STRAC, but there is no overall survival benefit. And so there's no clear consensus to use adjuvant sunitinib in the stage 3 setting. It is not certainly a category 1 or even category 2A recommendation. It is an option, but not one that is likely to result in any overall survival benefit for our patients. Before we really get into talking about treating patients with metastatic kidney cancer, we need to talk about our risk stratification models. The first one that was used historically, at least in recent memory, was the Memorial Sloan Kettering Cancer Center, or MSKCC, criteria, which included Karnofsky performance status, a low hemoglobin, a high corrected calcium, a short time from initial diagnosis to the start of systemic therapy, less than a year, and then a high LDH. And each one of these risk factors would be worth 1 point. If you had no risk factors, you had a good prognosis. 1 to 2 would be an intermediate prognosis. 3 or more would portend a poor prognosis. Now, this model was derived from studies in the interferon era of renal cell carcinoma. So it's based on older data in really an older era. And I have performance status, anemia, high calcium, and less than 1 year from diagnosis to systemic therapy in a different color, because we'll see that is similar to our updated model. Now, the updated model, the International Metastatic Renal Cell Carcinoma Database Consortium, sometimes called the IMRD or HANGS model, is derived from studies in the TKI era. It uses some of the same criteria of the MSKCC model, like performance status, anemia, high calcium, less than 1 year from diagnosis to recurrence or start of therapy, but it also includes an ANC above normal and a platelet count above normal. And again, the same thing, 0 risk factors is favorable, then 1 to 2 is intermediate, 3+ is poor risk. And this brings us back to the case of LL, who chose not to pursue adjuvant sunitinib, no overall survival benefit, but certainly toxicity. He goes 2 years until he has some lymphadenopathy on an abdominal CT. CT chest also shows a 2 centimeter lung lesion that is biopsied, consistent with clear cell renal cell carcinoma. His blood pressure is still well controlled on amlodipine. His labs that are pertinent include a normal creatinine, a normal albumin, and a normal calcium, a normal white count, a normal ANC, a normal hemoglobin, and normal platelets. His Karnofsky performance status is 90%. Which of the following is the most appropriate treatment option for LL? Ipilimumab plus nivolumab, cabozantinib, lenvatinib plus everolimus, or pazopanib? And the best answer here is pazopanib. He has a favorable risk. He has 2 years from diagnosis until he will start systemic therapy, and all of his labs are normal. So for favorable risk, a TKI alone like pazopanib would be the best option of what is listed here. So he is now scheduled to begin treatment with pazopanib 800 once a day. Which of the following should LL be monitored for throughout therapy with pazopanib? Signs of depression, thyroid function, hyperlipidemia, or hyperglycemia? And the correct answer here is thyroid function. Had he been started on the regimen containing everolimus, an mTOR inhibitor, then hyperlipidemia, hyperglycemia would be concerns with treatment. But thyroid function is the best option here, given the TKI he's on. The treatment of metastatic renal cell carcinoma has really, undergone a revolution over the last 20 years, which we'll see on the next slide. So going back 30 years, the mainstay of treatment for metastatic renal cell carcinoma was interferon alpha, or IL-2 for those that were very fit with a great performance status. Then in the early to mid-2000s, around 2005, we had sunitinib and sorafenib approved. Sunitinib was approved based on improved progression-free survival compared to the old standard of care, interferon alpha. Then we received approvals for mTOR inhibitors, everolimus and temsirolimus, which has some overall survival data in poor-risk patients based on the old MSKCC criteria compared to interferon. Then we got some of the next generation multi-kinase TKIs, pazopanib, axitinib, cabozantinib. And then in the last decade, we saw the arrival of the checkpoint inhibitors, nivolumab, pembrolizumab, atezolizumab, and avelumab. Before our immune checkpoint inhibitors, there was a thought that if we treated people with sunitinib in the first-line setting, that following progression, it would be better to use a different class. So the conventional wisdom was TKI, then an mTOR inhibitor. However, those studies actually showed when they were done that TKI followed by TKI, whether it be sorafenib or cabozantinib, was better than an mTOR inhibitor. We also saw that nivolumab in the second-line setting was better than everolimus. As such, mTOR inhibitors have somewhat fallen out of favor due to their lack of success in the clinical trials. And then just the most recent advance in the treatment of metastatic renal cell carcinoma is combination treatment in the first-line setting, adding either nivolumab with ipilimumab or VEGF targeting TKI plus an immune checkpoint inhibitor. So similar to bladder cancer treatment in the metastatic setting, where the first thing you do is figure out, are you cisplatin eligible or not? The first thing we do with metastatic renal cell carcinoma patients is risk stratify. In the case of LL that we went over, he had favorable risk. He had a risk score of 0, whether you use either criteria. So preferred treatment for favorable risk includes single agent sunitinib, single agent pazopanib, or combination axitinib plus pembrolizumab. If he had been intermediate or poor prognosis, our preferred initial treatments would have been nivolumab or ipilimumab or axitinib plus pembrolizumab as category 1 recommendations, with cabozantinib as a lower tier category 2A recommendation for those patients. In addition to sunitinib, pazopanib, and the axitinib pembrolizumab combination as preferred options for favorable risk, clear cell histology. And again, most of what we're talking about is clear cell renal cell carcinoma. Other recommended regimens included nivolumab plus ipi, axitinib plus avelumab, cabozantinib as a 2B recommendation, and then useful in certain circumstances would be active surveillance, high-dose interleukin-2, really only for those with excellent performance status and normal organ function, and then axitinib as a category 2B recommendation. So now let's go back to the beginning of the TKI era in metastatic renal cell carcinoma with this phase 3 study of sunitinib outperforming interferon alpha with regards to response rate and progression-free survival, with a trend and improvement in overall survival. So this kind of supplanted sunitinib as the standard treatment. Now, this was for all patients at the time with metastatic renal cell carcinoma. Sunitinib has been compared to pazopanib in the first-line setting. This is the COMPARE study. Again, metastatic clear cell renal cell carcinoma in the first-line setting. Pazopanib 800 once a day, standard dosing, or sunitinib 50 milligrams for 2 weeks, for 4 weeks, and then 2 weeks off, standard dosing of sunitinib. And COMPARE showed that sunitinib and pazopanib had fairly similar outcomes. There was a slightly higher objective response rate overall in the pazopanib arm, but similar progression-free survival and overall survival. And the primary endpoint here was non-inferiority, which pazopanib did achieve versus sunitinib. There was no difference by risk category with regards to overall survival between either TKI arm, but I do have them listed here so you can see that the favorable risk is really quite favorable, with the median OS above 40 months in either TKI compared to a median OS of less than 10 months in the poor risk group. And now going forward, we're going to see some differences in how these folks are treated based on whether they are favorable risk or not. So if sunitinib and pazopanib in the first-line setting have similar efficacy outcomes, we can look at their toxicity outcomes and see that pazopanib had more transaminitis, whereas sunitinib had more fatigue, more hand-foot syndrome, and more myelosuppression. We move from COMPARES to PISCES, which was a smaller study, 170 patients, randomized to either pazopanib or sunitinib for 10 weeks with standard dosing, then a two-week washout, and then crossed over to the alternative TKI with the primary endpoint of patient preference. And 70% of the patients preferred pazopanib, compared to just 22% preferring sunitinib. And this preference for pazopanib appeared to be because of less fatigue in people taking pazopanib and fewer taste alterations while taking pazopanib. So what we have here is pazopanib and sunitinib being relatively similar with regards to efficacy outcomes, but a patient preference relatively strongly in favor of pazopanib over sunitinib. So now if we look at our treatment guidelines for poor and intermediate risk clear cell renal cell carcinoma, we see there are two category 1 options, nivolumab plus ipilimumab, a combined immune checkpoint inhibitor regimen. Again, nivolumab, a PD-L1 inhibitor, and ipilimumab, a CTLA-4 inhibitor. The TKI axitinib plus pembrolizumab is also category 1, with cabozantinib as a category 2A recommendation. Other recommended regimens include pazopanib, axitinib, or the combination of axitinib plus avelumab, and then useful in certain circumstances, temsirolimus, high-dose IL-2, and axitinib. Let's talk Checkmate 214. This is the combination of ipilimumab plus nivolumab versus sunitinib in the first-line setting. These were patients with metastatic clear cell renal cell carcinoma, no prior treatment, Karnofsky performance status above 70% or 70%, stratified by IMDC risk. So they did make sure they had equivalent numbers of favorable, intermediate, and poor risk in each arm. They had some primary endpoints that I won't get into, but this is a large study of more than 1,000 patients randomized to either ipilimumab plus nivo, and the dosing here is ipilimumab 1 mg per kg plus nivo 3 mg per kg every 3 weeks for 4 weeks, followed by nivolumab indefinitely until disease progression or toxicity every 2 weeks, or standard dosing sunitinib 50 milligrams daily for 4 weeks, then 2 weeks off. Now, Checkmate 214 is very notable because it was really changed how we thought about treating renal cell carcinoma, basically displaying that there could be different preferred treatments based on risk. So on the left, if we look at our poor and intermediate risk patients, we see that ipilimumab plus nivolumab outperforms sunitinib with regards to overall survival, progression-free survival, and response rate. So you see there the 18-month overall survival, at a year and a half, 75% of those folks were still alive in the ipi-nivo arm versus only 60% in the sunitinib arm. So not just was ipi-nivo better for these poor and intermediate risk patients, but a fairly wide magnitude of benefit. Now, the study methods were changed mid-study to realign their statistical analysis to only look at and spend all their power on this poor and intermediate risk analysis. So they then have an exploratory analysis for the favorable risk, where we see that there is no benefit of ipi-nivo compared to sunitinib in the favorable risk patients. In fact, numerically, it appears that sunitinib is better than ipilimumab and nivolumab. But of course, this is an exploratory analysis that they decided to do halfway through the study, so there is no formal statistical analysis testing here. But clearly a trend that sunitinib is likely better than ipi-nivo in favorable risk patients, which is why we see ipi-nivo in the guidelines as a preferred first-line treatment only for poor and intermediate risk and not for favorable risk. Keynote 426 is the next study of combination axitinib plus pembrolizumab, the next combination regimen in this patient population compared to single-agent sunitinib. Very similar inclusion criteria, randomized to pembro 200 every 3 weeks, plus axitinib with a standard dose adjustments based on toxicity, or standard dose sunitinib. Now, this was published in the New England Journal of Medicine 2019. There was an update published right before the slides were due, which I will talk a little bit more about on that slide. So when we look at the results of Keynote 426, we see that axitinib plus pembrolizumab outperforms sunitinib in the entire population in terms of 1-year overall survival, median progression-free survival, and response rate. And that benefit in the New England Journal of Medicine publication 2019 appeared to be in all subgroups, regardless of PD-L1 benefit. And for that reason, the NCCN guidelines have axitinib pembro as a preferred option for both favorable and intermediate poor risk clear cell renal cell carcinoma. The only regimen that is in both the favorable risk and the intermediate poor risk as a preferred first-line option. Now, if you look closely at our forest plot here, you can see that our 95% confidence intervals for the intermediate and yellow and poor risk patients are relatively narrow and are statistically significant, not crossing 1. That favorable risk is relatively wide and does cross 1. And in a subsequent long-term follow-up published right after the final slides were due, we see this benefit potentially in the favorable risk category fall out of favor and move closer to actually closer to 1. suggesting that what we saw here was maybe just chance in the favorable cohort. It will be very interesting going forward to see if the NCCN guidelines change this axitinib plus Pembro as a preferred option in the favorable setting. Right now it is. And I'm mentioning this here for those of you really interested in keeping up with what is current. If you are taking the course to prepare kind of for the BCOP exam, I will note that they do not tend to test on topics that have changed very recently. So rest assured, if you are confused by this, things are moving constantly, especially in renal cell carcinoma and in all of oncology. CABOSUN is a phase 2 study comparing cabozantinib and sunitinib in about 150 patients with intermediate and poor risk clear cell renal cell carcinoma, so not favorable risk. And we see that cabozantinib outperforms sunitinib with regards to progression-free survival that was statistically significant, with a trend towards improved overall survival. And based on CABOSUN, we see cabozantinib as a category 2A option for those that had intermediate or poor risk based on this phase 2 trial. So we've already mentioned that for our intermediate and poor risk, whether it's pembrolizumab plus axitinib or ipilimumab plus nivolumab, that some immunotherapy-based regimen was better than a TKI alone. So when would you use a drug like cabozantinib, just a TKI? Well, that would be somebody with something like rheumatoid arthritis who may not be a candidate for immune checkpoint inhibitor therapy. Okay, the last slide on an immune checkpoint inhibitor TKI combination is avelumab plus axitinib. This is Javelin Renal 100, large study, almost 900 patients randomized to avelumab plus axitinib or single agent sunitinib. We see improved median progression-free survival with the combination arm, better response rate, including median PFS, both in the PD-L1 positive and the intention to treat combination. Now, the overall survival data is not mature, so this is not a preferred regimen, unlike, say, pembrolizumab plus axitinib. It is listed as another option in the across treatment groups by the guidelines. What you don't see here, if you're really following this space closely, is the nivolumab plus cabozantinib combination, which was just FDA approved in the last 4 to 5 weeks. And that'll certainly be incorporated into guidelines in the future. Again, for the BCOP exam testing purposes, they don't tend to write questions on topics that have changed very recently, such as some of these combinations. I do not have a time to say a whole lot about non-clear cell histology in renal cell carcinoma. It is a poorer prognosis than clear cell histology, which is the more common subtype. And one of the ways you know right away that we don't have great options and a great idea of what to do is that one of the preferred regimens here is clinical trial for non-clear cell metastatic renal cell carcinoma or sunitinib. You can see there that other recommended therapies include TKI or a combination of lenvatinib plus everolimus. And then a fairly long list of useful in certain circumstances. I'll just highlight the bevacizumab plus erlotinib, which is for selected patients potentially who have advanced papillary renal cell carcinoma. And then temsirolimus is a category 1 option for those poor risk patients, and that's based off improved overall survival compared to interferon alpha using the old MSKCC risk criteria. Well, I mentioned that BCG was one of the earliest forms of immunotherapy. So was interleukin-2. High-dose IL-2 produced relatively low response rates of 15%. But in those who had a response, the median duration of response was 54 months, which is excellent. That's the good. The bad is this is extremely toxic to dump a big dose of a cytokine into your blood, with 74% of patients having grade 3 or 4 hypotension. You know, they need like pressors in the ICU. Oliguric renal failure, very common. So this is only recommended for highly selected patients and is likely not something you'll see a whole lot now that we have much safer immunotherapy options like nivolumab, pembrolizumab, etc. So let's get back to LL, who had favorable risk, and he was treated for 9 months with pazopanib. He had some dose reductions for transaminitis. ECOG performance status declined a little bit from 0 to 1. His imaging shows disease progression. What's the most appropriate second-line treatment for him? Cabozantinib, nivolumab plus ipilimumab, high-dose IL-2, or everolimus. And the best answer here is cabozantinib, which we will see in coming slides. He's certainly not a candidate for high-dose IL-2 now that his performance status has declined. We're going to start talking now about second-line treatment, and we don't have as much time to get into as much depth on second-line therapy as we did for first-line therapy with metastatic renal cell carcinoma. So you can see for subsequent therapy, so after first-line therapy for clear cell renal cell carcinoma, the preferred first-line treatment, or not first-line, the preferred treatments for second-line therapy would be cabozantinib or nivolumab as category 1 recommendations, with nivolumab and ipilimumab combination as a category 2A recommendation, which in our previous case, cabozantinib was the better answer than combination nivo-ipi as a category 1 recommendation. Other recommended regimens could include axitinib, lenvatinib, and everolimus. Both have category 1 in this other recommended regimen. And then you can see they're useful in certain circumstances, some of the same drugs that we have talked about before. So just to wrap up renal cell carcinoma, for stages 1 to 3, treatment is surgery. There's not a well-defined role for adjuvant treatment in the stage 3 setting for immunotherapy or TKIs at this point. In the metastatic disease setting, we do risk stratify favorable risk versus intermediate and poor risk. Now, for favorable risk disease, it appears that TKI alone is probably the best strategy, so pazopanib or sunitinib. I mentioned the axitinib plus pembrolizumab combination is a preferred first-line regimen for favorable risk. Based on the most recent follow-up of that landmark Keynote 426 study, they only saw the benefit in the intermediate and poor risk section. So if I were to forecast or predict or look ahead, I think that we'll see that fall out of the recommendations in the future. Again, very fast-moving field in renal cell carcinoma. For intermediate and poor risk, we do see that immunotherapy appears to be more effective, whether it's combination immunotherapy, nivolumab plus ipilimumab, or combination of a TKI like axitinib plus pembrolizumab. And then we do have several options in the second-line setting that have been validated post TKI in the first-line setting. And really going forward, what are the ideal treatments post immunotherapy? We really don't know at this time. So that concludes what I have to tell you about bladder cancer and renal cell carcinoma. So that concludes this presentation. Thank you for participating.